Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
Thank you and good morning. I hope this finds everybody well. Today we're going to discuss transcatheter aortic valve replacement in 2017, the supporting data and future directions in which the field will be going in. Here are my disclosures. So to begin, we have to look at major occurrences that occurred within transcatheter aortic valve replacement in 2017. We have seen the approval for intermediate risk patients in both Europe and the United States. We have seen multiple randomized trials embarking on expanding TAVR to both low risk and asymptomatic patients. We have seen publication of randomized data on cerebral embolic protection accounting for FDA approval. And because of this, we recognize that TAVR is rapidly expanding, technology and techniques are improving, and we're going to go over all of that this morning. I think in order to understand TAVR, we have to first understand what different levels of risk are. If we look back at the 2014 AHA-ACC guidelines, you can see that individuals who have an STS risk of 4 or less, who are not frail, who do not have major organ system impediments, they would be considered low-risk individuals, and right now would be candidates for surgical aortic valve replacement. But as we move forward to the right of the screen, intermediate, high risk, and prohibitive risk, you can see that as your STS score increases, as your frailty increases, as your organ system's involved, we can see that your degree of risk significantly increases. Laying the groundwork for what low risk, intermediate risk, high risk, and prohibitive risk is allows for us to better understand the field of transcatheter valve replacement. If we look at extreme risk, which is where all of this began, the foundational trials tested this new therapy in individuals who were considered not surgical candidates. Both the US CoreValve pivotal trial as well as the Partner 1B trial looked at medical therapy versus transcatheter aortic valve replacement. And Partner showed at 3 years a significant reduction in mortality of about 30% over medical therapy alone. And as you can see, very similar results were seen with CoreValve in their pivotal trial in the United States. We then moved on to high surgical risk patients, randomizing patients to transcatheter valve replacement versus surgical valve replacement in both the CoreValve pivotal trial as well as the Partner 1A trial. And what we saw is that at 5 years, regardless of SAVR or TAVR, individuals were pretty much identical. So therefore, it was the first confirmation that transcatheter valve replacement is a reasonable alternative to surgical valve replacement in high-risk individuals. If we look at the CoreValve trial, this also showed the same. There was even a survival advantage with transcatheter aortic valve replacement when the curves diverged at 3 years. Because of these trials, we recognized the guidelines in 2014 were subsequently changed, stating that TAVR is recommended for patients who are considered prohibitive risk and have a 1-year survival expected post-procedure, and it is a reasonable alternative to surgical valve replacement in those individuals who are considered high risk. We then moved on to intermediate risk individuals. We had randomized data looking at transcatheter valve replacement versus surgical valve replacement, utilizing the SAPIEN XT and the SAPIEN 3, as well as the CoreValve. And what we found is that Partner 2A portion said TAVR with SAPIEN XT was non-inferior to surgical valve replacement with respect to mortality and strokes 2 years can be seen. And in those individuals who can undergo a transfemoral TAVR, there was actually a benefit to both mortality and stroke. So this study generated convincing evidence that transfemoral TAVR provided an outcome advantage to intermediate risk patients and the significant reduction in mortality and disabling stroke in comparison to surgery. The other important point about intermediate risk patients is their quality of life. You can see by this graph here that both transcatheter valve replacement and surgical valve replacement significantly improved quality of life. But as you can see, that functional recovery in the KCCQ at 1 month was significantly higher for those individuals who underwent TAVR because of the fact that there was no surgical incisions, no pain from sternotomy. Eventually, the curves catch up, but the benefit of this was driven by the fact that in individuals who underwent a transfemoral TAVR, they can much quickly get back to their normal quality of life. The intermediate risk with respect to CoreValve also showed superiority or equivalency with a trend toward superiority for the CoreValve. Because of this intermediate risk patients, we've had regulatory approval. In Europe, in August of 2016, the Evolut R was approved for intermediate risk patients. In September of 2016, the SAPIEN 3 was subsequently received CE mark. The FDA approved the SAPIEN 3 and SAPIEN XT for intermediate risk patients in August of 2016, and in July of 2017, the Evolut R obtained FDA approval. So we can see that we are moving now into the intermediate risk population. Because of this, the 2017 ACC/AHA focused update said that TAVR is now a reasonable alternative to surgical AVR for symptomatic patients with severe aortic stenosis who are intermediate surgical risk depending on patient-specific procedural risks, values, and preferences. So we know that now TAVR has become the gold standard treatment for patients with severe symptomatic aortic stenosis at extreme risk, with a significant reduction of approximately 30% in mortality with respect to standard medical therapy. We know that high-risk patients, TAVR was non-inferior to surgical, and with the CoreValve study, may be actually an advantage over surgery. And the recent rigorous data which we have has confirmed that TAVR is at least non-inferior to surgical valve replacement with respect to survival in this patient population. So with the robust clinical trial results that we have, TAVR has been rapidly implemented across the world. You can see that valve implantation is essentially everywhere on every continent, and you can see that over 250,000 implants have been seen in both the United States. What about treatment trends? Well, half of the procedures occurred in established markets. If we look here between 2013 and 2015, you can see over 100,000 TAVRs were performed in Italy, the United States, the United Kingdom, and Germany, as can be seen by this bar graph here. And it's estimated that by 2025, there will be over 300,000 TAVRs performed worldwide. That's a 4-time gross over the next 10 years. If we look at data which we have so far, between 2012 and 2015, surgical procedures in adult patients remain stable at about 29,000 per year. Whereas if we look at the TVT registry, we've had a 400% increase in the same time frame as TAVR. And the suspicion is that in 2016, the curves will actually cross and we will see that more patients are being treated with transcatheter valve replacement than they are with surgical valve replacements. What about age? Well, the interesting thing is that we have seen very little evidence of age creep, meaning that this procedure has not typically creeped into a younger patient population. Looking at the United Kingdom registry, the TVT registry, and the German registry, you can see that the average age still remains around 80 years of age. But what we have seen is risk creep. If we look at the risk of individuals undergoing transcatheter aortic valve replacement, this is looking at log Euro score, you can see that the log Euro score of individuals being treated is decreasing. This is also seen in both the United States and the UK, where if we look in 2012, our average STS score was 7.1, in 2015 we're 6.3, and the Euro score in the UK began around 22 in 2012 and has reduced to 18 in 2015. So we see that there is a creep with respect to risk, but not a significant creep with respect to age. What type of valves are being used? Well, looking back at our 2015 data, you can see that approximately 60% of cases performed globally are being performed with the balloon expandable valve, whereas about 40% are being performed with the self-expanding valve. So we see that TAVR is growing rapidly and is mainly being applied to patients around the 80 years of age. We see that older patients, even those with lower surgical risk, are benefiting from these minimally invasive procedures. We expect a 4-time growth in centers by 2025. And if we take a look at the number of baby boomers, we would expect that TAVR will see a large new population going forward. The one thing that we've learned from TAVR over time is that we can always build a better mousetrap. You can't just sit on your laurels with the technology that we have now. If we look at the functional devices that we began with initially, the initial SAPIEN device, the CoreValve device, and the SAPIEN XT device, there was complications such as stroke, conduction disturbances, paravalvular leak, and vascular trauma. And if we look at these foundational devices, the weighted average was about 4% across the board in the studies. If we look at pacemaker implantation post device placement, it was approximately 12% in all of the early trials. If we look at vascular complications, it was about 8% looking at the early trials with the initial devices. And if we look at paravalvular leak, approximately 34% had mild post-procedure, and moderate to severe was seen in about 10% of patients, even higher in some studies. Well, we have new devices now, and these devices have been designed to mitigate these complications through their design and the fact that they are not only smaller, but better prepared. If we look first of all at the SAPIEN 3 device, you can see it's a balloon expandable chromium frame. As you can see on the outside of the device, there is a skirt to prevent your paravalvular leak. We have more sizes, 20, 23, 26, and 29 millimeters to treat a wider range of annular sizes. And we use a expandable 14 French sheath or 16 French sheath, which will subsequently allow for delivery in the majority of patients which we're treating. The Evolute R, likewise, self-expanding nitinol frame with a porcine pericardial supraannular valve. There is a seal zone at the bottom of the valve. It is recapturable, so you can go ahead and place it and subsequently recapture. There are 4 valve sizes, and it is also 14 French equivalent. In comparison to our early studies, which were 18, 20, 22 French, we see a significant improvement in French size for our delivery system. And the 34 system, which allows you to treat larger annulus, has a 16 French equivalent requiring vessels greater than 5.5. The Evolute has subsequently undergone another generational change with the Evolute Pro. As you can see here, the skirt, which has been subsequently raised at the bottom of the valve, allows for extended sealing and decreased evidence of aortic insufficiency post-procedure. It allows for you to treat annulus between the sizes of 17 and 26 with 3 valve sizes. It is a little bit larger. It is a 16 French profile, but can accommodate vessels up to 5.5 millimeters. The Lotus valve, which is from Boston Scientific, as you can see, is a mechanically braided nitinol frame. It is made of bovine pericardium. On the bottom of the device, you can see an adaptive seal zone so that there is minimal paravalvular leak. It is repositionable and recapturable. You don't have to pace in order to deploy it, and you have 3 valve sizes to go ahead and treat annulus between the sizes of 20 and 27. It's an 18 French sheath and therefore would require a vessel of at least 6 millimeters. The Portico valve from St. Jude, which is now Abbott, finishing trials. It also is a self-expanding nitinol frame. It has intraannular bovine pericardial valve. It is resheathable, recapturable, and rapid pacing is not required for this device. There are 4 valve sizes, which allow for you to treat a wide size annulus range, and it is 18 French for the 23 and 25 and 19 French for the 27 and 29. And the Accurate Neo valve, which is still in trials, is likewise, you can see, both inner and outer pericardial skirts to minimize your paravalvular leak. So in looking at the data, if we look at real-world data shows that there are 45 unique cohorts are identified. If we look at SAPIEN 3, Evolute R, the Lotus, the Accurate, and the Portico, you can see the number of valves which are being utilized, with SAPIEN 3 edging out Evolute R currently. If we look at the stroke risk is down at 4% or less with the new valves. In earlier trials, you can see it was showed that it was much higher than that, and also the SAPIEN 3 trial showed a stroke risk of about 2% at 30 days. So now we would say, if we look at all the trials that we have here, beginning to end, that the weighted average is somewhere around 3.5% stroke risk under current generation devices. Permanent pacemakers, you can see, is very sensitive to your device type. Rates currently are about 15% with the Evolut R and the SAPIEN 3, but you can see with the Lotus valve, it is significantly higher. Typically, as you try and eliminate paravalvular leak with skirts and a bulkier device, that is typically an account for an increased rate of pacemaker implantation. We know that moderate, bordering to severe, and severe or worse does account for a mortality diminishment in patients, so you have more mortality in those individuals who do have significant paravalvular leak post-procedure, which is why we're attempting to go ahead and reduce it with our new devices as much as possible. We are still looking to see if pacemaker implantation does account for mortality. There have been a few small studies which have shown that pacemaker implantation also does increase mortality post-procedure. And here you can see the degree of paravalvular leak as 5 or less. Vascular complications, because the devices are smaller, you can see that they are down to 5% or less as well. And because of the fact that we have smaller devices, if we look at access points over time, you can see that in the early beginning, we had a very high rate of both femoral and transapical. We now see that majority of patients are being performed transfemorally with a significant reduction in transapical. Transaortic is increasing, and you can see down at the bottom, other, a left subclavian approach for patients who do not have vasculature of the lower extremities to allow for device passage is also a very nice approach which we use routinely. But if you look at overall, the majority of patients are being performed from a transfemoral standpoint. So the new devices which we have had significant design improvements, smaller delivery systems, recapturable, sealing technologies which improves the safety profile of TAVR, lower rates of stroke and clinically relevant PVR are better. The devices also allow for the application of TAVR to more patients from a transfemoral approach, and we can even streamline your patients and do them under conscious sedation, which we'll talk about in a minute. If we talk about stroke prevention, we now have an FDA-approved Sentinel device. The Sentinel device is essentially a two-basket device which is placed into the brachiocephalic as well as the left common carotid artery. It does prevent any embolic debris from getting up into the brain. This was the trial design. If we go ahead and look at the patients who had captured debris, about 99% of patients had captured debris. And if you look at when they went ahead and evaluated what it was, you can see that there's a tremendous milieu, if you will, of different types of material. If we look at 30-day MACE event rates, it was reduced in those individuals who underwent Sentinel device. And the stroke rate is what drove this. If we actually look at this data at 48 hours, there was a statistically significant difference in stroke rate between those individuals who underwent protection and those who did not. Because of the trial data showing a benefit towards the device, it underwent FDA approval in June of this year. What about anesthesia for these procedures? Well, because of the fact that we have a transfemoral approach, we have better devices, we have reduced paravalvular leak, we can now do most of these patients under conscious sedation. If we look here, what percentage of patients actually underwent general anesthesia, you can see that the numbers on the newer trials are significantly decreasing. What have we found? Well, if you look at the Source 3 registry, anesthesia was not randomized, so it could be impacting it, but it shows that outcomes with SAPIEN 3 are independent of the anesthesia type, and it's reasonable to leave this choice to the operator. If we look at the TVT registry data from 2015, you can see that in looking at acute kidney injury and looking at life-threatening bleeding and looking major bleeding and length of stay, it was all significantly reduced by using conscious sedation. This allowed for our institution to implement a fast-track protocol where patients are performed under just local anesthesia and conscious sedation. They have their procedure performed. They go directly from our hybrid operating room to the cath lab recovery area. They have a 2-hour recovery period, at which point they'll typically be fast-tracked to a telemetry bed for discharge within 24 to 48 hours. If there are any adverse events during that 2-hour monitoring time, then they'll go to the ICU for further monitoring and evaluation. So what does the future hold for transcatheter aortic valve replacement going forward? Well, we have low-risk trials. Here are the active trials which are currently enrolling. You have the Medtronic low-risk trial, which are 80 sites in the United States. You have the Partner 3 trial in the United States and Canada, looking at the SAPIEN 3 transfemoral. The interesting thing and the important thing about these are that they're going to have 10-year follow-up, and they're all going to have CT data on the function of the valve long-term. We have the UK TAVI and the Notion 2, which will have 5-year follow-up in these patients which are enrolled in these trials. If you look here at the low surgical risk trials, the primary endpoint is going to be death or major stroke at 2 years within the Medtronic low risk trial, and Partner 3 is going to be almost identical at 1 year. The patients are going to be severe symptomatic AS with an STS score, as you can see, of 3% or 4 per less respectively. Patients are going to be randomized 1-to-1 to surgery or transfemoral transcatheter aortic valve replacement, and the devices are going to be the Evolut R and the SAPIEN 3. If we look at the exclusion criteria, bicuspid valves are excluded for both severe multivessel CAD, MI within the last 30 days, severe MR or TR, severe AI or MR, as you can see in the Partner 3, significantly reduced left ventricular function, moderate mitral stenosis. So you can read on here that it's going to be a very clean trial to go ahead and evaluate your true low-risk patients in comparing surgical valve replacement versus transcatheter valve replacement. We also, as you can see here, the TAVR Unload. TAVR Unload is going to be comparing medical therapy in patients with moderate aortic stenosis with symptoms of heart failure and reduced ejection fraction. And early TAVR is going to be looking at those individuals who have severe aortic stenosis and are asymptomatic. So it'll be interesting to see the results of these trials going forward. What do we have to be concerned about long term? Well, the one thing that everybody talks about with TAVR is valve durability. Here you can see a valve which is explanted at 1 year because of valve failure. The other is going to be being able to re-enter coronary arteries post transcatheter aortic valve replacement. These are two things which we have to be very cognizant of, specifically in a younger, healthier population. If we look at the older data, valves have been implanted to patients out to 9 years with still good functional performance. What about bicuspid valves? Well, we see these frequently in younger patients. When TAVR is applied to all comers, the anatomy becomes an important issue. Significantly more work needs to be done to learn about the optimal implant techniques. If you look at this percent of patients with aortic valves, you can see that it is mostly going to be the younger patient population that we are going to be seeing. The older patients are going to have trileaflet calcific aortic stenosis. What about aortic insufficiency? Aortic insufficiency for transcatheter valve replacement is an entirely different animal. As you look here, we know that it is the calcium of the valve that allows for us to go ahead and place our transcatheter valve and prevent its migration and allow for its proper function. Conversely, with aortic insufficiency, there is a little bit of calcium. You have a dilated root, and frequently you're also going to have a dilated ascending aorta. There are a number of devices which are being looked at for treating patients with aortic insufficiency, as can be seen on these slides. And there's been a number of 13+ reports looking at 127 patients that are looking at individuals being treated with TAVR for aortic insufficiency. What have we found? Well, the majority of patients are being treated with a self-expanding valve. The success rate is anywhere between 74 and 100%. 7% of patients required more than one valve to allow for sealing. 2.5% were converted to surgical valve replacement, and your all-cause mortality at 30 days was 7%. So for aortic insufficiency, I would say that as of now, surgical aortic valve replacement is going to be your gold standard. Among selected patients with pure native AI deemed at high risk for TAVR, for surgical valve replacement, then TAVR may be technically feasible with an associated but acceptable risk of early mortality. Two valves which have been looked at in this patient population extensively, the J valve and the Gina valve, are not yet available in the United States. Right now, the CoreValve would be the preferred self-expanding valve. And alternative access points, transapical, transaortic, and subclavian, may be actually better for less valve mobility and more precise placement. We'll have to stay tuned. If you look at this, these individuals also suffered more acute kidney injury a higher rate of permanent pacemaker implantation, and a higher degree of moderate or severe aortic insufficiency post-procedure. So we know that TAVRs are proven in patients with intermediate surgical risk because of the robust data that we have. There's significant investment looking at younger and healthier patient populations. We have to do careful studies in this because we know that there are TAVR-specific complications. However, we know that there is a survival advantage and a quick recovery to their normal quality of life with transfemoral TAVR, and the intermediate risk trials have been very encouraging. It is also possible that TAVR will provide an alternative therapy to patients with aortic stenosis and heart failure, and also asymptomatic patients. Overall, the future looks very bright for transcatheter valve therapies, with a greater than 300,000 patients expected to be served annually within the next 10 years. And I'd like to thank my colleagues who allow for us to go ahead and perform this procedure week in and week out, putting our patient first each and every time.